Good day. My name is Josephine Lucero Sacdalan, and today I will be discussing the approach to pancytopenia. Our objectives are as follows. First, to define pancytopenia and review the common etiologies. Second, to emphasize the clinical findings that warrant more urgent evaluation. And third, to illustrate the approach to the evaluation and basic management of conditions presenting with pancytopenia. Pancytopenia is defined as a decrease in all three blood cell lines. That is hemoglobin, white blood cells, and platelets. Normal parameters will vary by age and sex. And for adults aged 20 to 80 years, normal parameters for males and females are seen on the table to the right. However, each institution will establish their own reference ranges, and these will be indicated on reports. Published reference standards by the World Health Organization use the following cutoffs: hemoglobin less than 12 in non-pregnant women and less than 13 in men, platelets of less than 150, and for white blood cells, the absolute neutrophil count is more informative. An count of less than 1,800 is considered neutropenia. There are many etiologies to consider when evaluating pancytopenia. These are categorized broadly into two. First is impaired production, including bone marrow failures of production or aplasia, both primary and secondary, nutritional deficiencies, as well as bone marrow infiltration with cancer, fibrosis, infections, or metabolic disorders. The second process involves blood cell destruction or sequestration, which can be autoimmune mediated from primary autoimmune disease, or those following malignancy, disseminated intravascular coagulation, thrombotic thrombocytopenic purpura, and splenic sequestration. And finally, these processes may be combined. For example, in a patient with lymphoma, malignant cells may infiltrate the bone marrow or the spleen, and treatment may also cause myelosuppression. In a non-malignant example, Crohn's disease, nutrient absorption is impaired, affecting hematopoiesis, and an overlying inflammatory state can contribute to ongoing cytopenias. Let's take a closer look at the causes. First, impaired production. Aplastic anemia, or AA, is marked by a failure of hematopoiesis. Though it is termed anemia, its main feature is the near absence of hematopoietic precursors presenting with pancytopenia. Acquired causes include an autoimmune destruction of the hematopoietic stem cells, but also drugs and radiation can damage these bone marrow cells. Likewise, infections can cause aplasia and usually are more commonly caused by viruses. And in the Philippines, tuberculosis is an important differential. Congenital aplastic anemia may also occur even in adulthood and usually present with other syndromic features. Impaired production may also be due to ineffective erythropoiesis, such as in the case of nutritional deficiencies of folate, vitamin B12, or copper. Myelodysplastic syndrome, on the other hand, is characterized by immature, poorly formed, or poorly functioning blood cells. Some of the medications reported to be associated with pancytopenia are now shown on the screen, but it's important to remember that association does not prove causality, and I also have not included chemotherapy medications where myelosuppression is anticipated. As you can see from the table, many medications have been reported, including aspirin, ibuprofen, captopril, diuretics, albendazole, sulfonamides, HIV medications, anti-seizure and antipsychotics, gout and thyroid medications, and immunosuppressants. Evaluation of an adult with pancytopenia must include medication history. Its dose, duration of intake, and the patient's renal and liver function may contribute to the risk for pancytopenia. In other cases, however, it's idiosyncratic, and withdrawal of the offending drug allows for count recovery. Impaired production may also be caused by bone marrow infiltration. In this etiology, there is no space for normal hematopoiesis to occur. In diseases such as malignancies, autoimmune granulomatous or metabolic diseases are included. Myelofibrosis, which presents with extensive scarring in the marrow, is another example. The second broad category of pancytopenia is due to blood cell destruction or blood cell sequestration, which can be autoimmune mediated, such as in diseases of lupus, rheumatoid arthritis, psoriasis, lymphoproliferative syndromes, and even chronic lymphocytic leukemia. However, these may more commonly present as isolated cytopenias. Due to many intersecting factors, we must also consider effect of medications, infections, and autoimmune fibrosis. Disseminated intravascular coagulation and thrombotic thrombocytopenic purpura also cause peripheral destruction, and splenic sequestration can be seen in those with cirrhosis, heart failure, malignancies, hemoglobinopathies, and other infections. In a review of literature of Asian cohorts presenting with pancytopenia, there is available published data from India, Singapore, Nepal, and China. In these reports, these are the more common causes of pancytopenia, listed in descending frequency. Aplastic anemia and megaloblastic anemia come first, followed by myelodysplastic syndrome and acute leukemia, then followed distantly by hypersplenism, infections, and drug-induced causes. Let's discuss a case. A 51-year-old female seeks consult due to progressive fatigue for the past 3 months, accompanied by fever for the past 3 days. She does not report any recent travel. Her vital signs show blood pressure of 110/70, pulse rate of 118, temperature of 38.3, and saturation of 99% on room air. Physical examination was unremarkable except for pallor and a systolic murmur at the second left parasternal border. She recently had her annual examination last week as required by work, which showed the following: hemoglobin of 42, hematocrit of 13.2, MCV of 114.3, MCH of 34.9, MCHC of 30.6%, WBC of 3, absolute neutrophil count of 1,900, and platelets of 64.5. What is or are your next steps? A. Request additional laboratories listed. B. Start ferrous sulfate and follow up in 1 week with laboratory results. C. Admit the patient to the hospital and refer urgently to a hematologist. Or D. Transfuse packed red blood cells. Going back to the case, I have highlighted the details of importance: her age, symptoms, the duration, her vital signs and examination findings, and her laboratories are pertinent for a hemoglobin of 42, WBC of 3 with an absolute neutrophil count of 1,900, and platelets of 64.5, all pointing to pancytopenia. Of the 4 options, only B would be inappropriate. A, C, and D are all appropriate, and of the 3, C would be most because of her symptomatic anemia. However, doing these 3 in conjunction will also be wise. So it's important to recognize when pancytopenia is urgent or a medical emergency. Some questions to ask yourself include: how severe is the pancytopenia? What is the trajectory of the pancytopenia? Is the patient stable? Are there other medical complications that will make him or her unstable in the next few days? And is there need for urgent treatment? In terms of numbers, neutropenia with fever or evidence of infection, or any new diagnosis of neutropenia below 1,000 or even 500, symptomatic anemia, and for thrombocytopenia when platelets are below 10, or when they are below 50 with clinically significant bleeding. These numbers present an urgent need to evaluate the pancytopenia. Furthermore, when there is clinical suspicion of any life-threatening condition, evaluation and management is urgent. These conditions include acute leukemia, disseminated intravascular coagulation, or hemophagocytic lymphohistiocytosis, which usually presents with fever, hepatomegaly, lymphadenopathy, high serum ferritin, liver function abnormalities, and coagulopathy. Urgency is paramount also when peripheral blood smears show immature cells such as blasts, or when they signal microangiopathy in the form of schistocytes. When accompanying blood work reveals metabolic emergencies such as hypercalcemia or elevated creatinine in the background of pancytopenia, these also warrant medical urgency. In contrast, when patients are asymptomatic and pancytopenia is long-standing, in comparison, of course, to historical blood work, a referral may be less urgent. So it's always important to review any previous blood work that your patient may have had. Let's go back to the case. You decide to admit the patient, and on further evaluation, she tells you that she is a breast cancer survivor and that she has been a vegetarian for the past 3 years. Your requested laboratories have shown the following: her peripheral blood smear shows moderate anisocytosis, leukopenia, and thrombocytopenia with no immature cells seen, corrected reticulocyte count of 0.5%, LDH of 2000, vitamin B12 of 160, folic acid of 3.9, with the rest of her blood work being normal. Which information would be useful to evaluate her pancytopenia? Is it her history of breast cancer, her dietary intake, her current medications, or any family history of blood disorders? So the pertinent information she shared include her previous cancer history, her current dietary habits, and the blood results did not reveal any immature cells. The corrected reticulocyte is at the lower limit of normal, LDH elevated, and the vitamin B12 and folate are mildly low. All of the information will be important. The evaluation of pancytopenia relies on a very good history and physical examination supported by focused laboratory examinations. A comprehensive history should outline the severity and duration of symptoms, paying particular close attention to the following. You should look for any recurrent, severe, or unusual infections, prolonged bleeding after simple procedures such as dental extractions or even flossing, or prolonged menstruation, any easy or very widespread bruising, or constitutional symptoms such as fever, night sweats, and unintentional weight loss will be important. Previous treatments and medications and medical conditions are important details as well. The geographic location, any travel, and understanding of endemic illnesses in relation to these locations will be informative. In the Philippines, malaria and tuberculosis are important differentials to consider. Finally, exposures and socioeconomic conditions can identify possible nutritional deficiencies, alcohol-induced or HIV-associated cytopenias. The physical examination tells us a lot about the clinical stability of the patient, but they can also reveal presence of rashes, oral lesions, lymphadenopathy, and splenomegaly. Rashes can tell us about any drug reactions or any ongoing rheumatologic disorders, or those that are specific to certain infections. Some oral lesions may also indicate immune compromise or other rheumatologic disorders. When examining for lymphadenopathy, on the right are important lymph node regions, which include the cervical, deltopectoral, axillary, epitrochlear, inguinal, and popliteal areas. We should not limit ourselves to just the cervical region. Initial laboratories that will be most informative include a repeat complete blood count with reticulocyte count at an established laboratory, a peripheral blood smear, coagulopathy tests including PT and PTT, renal and liver function tests, electrolytes, lactate dehydrogenase, calcium, uric acid, and blood typing and screening. Returning back to the case, the patient tells you that she was diagnosed with breast cancer 10 years ago. She received chemotherapy and radiation followed by tamoxifen for 5 years. She currently takes a multivitamin tablet daily, and although she is a vegetarian, she eats eggs and cheese. No one in her family is known to have a blood disorder. You transfuse her with 2 units of packed red blood cells, which has increased her hemoglobin to 71. What are your next steps? A, investigate the cause of her fever. B, start supplemental folic acid and vitamin B12. C, discuss with the hematologist about the need for a bone marrow biopsy. All 3 are correct. While her neutropenia is not below 1,800, investigating the etiology of her fever is still important. Her folate and vitamin B12 are borderline low, and she would benefit from supplementation, but this would not fully explain her pancytopenia, and she would benefit from further workup, including a bone marrow aspirate and biopsy. The patient was seen by her hematologist colleague who performed the procedure, and it showed a markedly hypocellular marrow with no maturing hematopoiesis. On the left is a representative picture of what an aplastic anemia bone marrow would look like, and on the right is that shows normal hematopoiesis. When other infectious etiologies are ruled out, this finding is consistent with aplastic anemia. Initial management of pancytopenia focuses on stabilizing the clinical situation. Of important note, if the patient is stable, certain laboratories such as a peripheral blood smear and the reticulocyte count, as well as red cell folate, are more informative when taken prior to transfusions. Ferritin, transferrin, haptoglobin, vitamin B12, and LDH are not significantly affected by transfusions, but it's important to never delay life-saving treatment. Transfusion support aims to treat symptomatic anemia and bleeding, and likewise to reduce risk of spontaneous bleeding. Febrile neutropenia must be investigated thoroughly, sending for cultures, relevant imaging, and starting broad-spectrum antibiotics, because an uncontrolled infection can lead to the patient's demise faster than low blood counts. This table provides an overview of the management of common causes of pancytopenia. For acquired aplastic anemia, we would offer immunosuppressive therapy with antithymocyte globulin, cyclosporin with or without L-thrombopag, or also evaluate the appropriateness of an allogeneic bone marrow transplantation. Megaloblastic anemia should receive vitamin B12 and or folate supplementation as clinically indicated. Myelodysplastic syndromes receive transfusion support, erythropoietin-stimulating agents, as well as chemotherapy if indicated. Acute leukemia will be evaluated for chemotherapy and receive transfusion support. Hypersplenism and infections focus on the underlying cause, and withholding the offending drug should be effective at resolving the pancytopenia. Moving on to some specific situations that may be of importance. When pancytopenia is accompanied by other clear signs and symptoms or laboratory results, there are certain next steps that should come into your mind. When pancytopenia presents with coagulopathy, as seen by prolonged PT and PTT, a peripheral blood smear becomes very important for you to look for signs of microangiopathy. And if this is present, you should think of DIC, TTP, sepsis, or leukemia. And if not, maybe there is an underlying liver disease. When there are clear abnormal peripheral smear findings, such as blasts, dysplastic cells, or nucleated red cells, a referral to a hematologist or pathologist is important, and eventually the patient may need a bone marrow evaluation. When pancytopenia is accompanied by reticulocytopenia, this is more likely a cause of a bone marrow aplasia or infiltration. In the presence of splenomegaly or liver disease, think of any systemic diseases, infections, malignancies, extramedullary hematopoiesis, storage diseases, or even HLH. When accompanied by lymphadenopathy, an important test to do is imaging. This is to determine the extent of the lymphadenopathy throughout the whole body. And think of malignancies or autoimmune diseases or infectious diseases. When pancytopenia is accompanied by other autoimmune symptoms, consider intersecting etiologies and evaluate any previous treatment received as well. And when pancytopenia is accompanied by fever, night sweats, or weight loss, think of infections, HLH, malignancies, or autoimmune conditions. In summary, pancytopenia is a decrease in all three blood cell lines with a wide list of possible causes. But the most common causes that present with significant pancytopenia include aplastic anemia, megaloblastic anemia, myelodysplastic syndrome, and acute leukemia. Hypersplenism, infections, and drugs are also possible. The urgency of evaluation and management depends primarily on the severity and duration of symptoms, and managing of pancytopenia focuses on stabilizing clinical status, followed by a thorough investigation to identify the cause. Thank you for your kind attention.